Okay, so good morning everybody and welcome members of Barnsley Clinical Commissioning Group to our governing body, and welcome to members of the Barnsley public. Good morning. So first of all, housekeeping. I think we're all in different places because we're on Teams, so make sure you're aware of how to keep safe. Also, we're on Teams, so we're going to ask people to maintain Teams etiquette and put the hand up when they need to speak using Teams. So, Kay, do we have any apologies?
We do. We have apologies from Dr. Mark Smith, and Dr. Kadasha may be late.
Right. And are we quorate?
We are quorate.
Good. So, Jane, would you introduce our patient story video?
Thanks, Chair. So the South Yorkshire and Bassetlaw Integrated Stroke Delivery Network has been working together with colleagues from Barnsley Hospital to raise awareness of stroke and the brain-saving treatment that is available. Data has indicated, as we know, that suspected stroke patients in Barnsley present later to emergency services than others in the region, and sometimes self-present to Barnsley Hospital. So what that means is they do not access hyperacute care, or their access is delayed, resulting in delayed urgent treatments such as thrombolysis. Mandy, who we'll see in the video, is a stroke survivor from Barnsley, and she was keen to raise awareness of stroke and the importance of seeking urgent help by dialing 999. She also wanted to raise awareness about urgent treatment, and the Barnsley team were also keen to ensure that patients arrive at the right place and at the right time to receive hyperacute stroke care. So thank you, Kirsty.
Kirsty.
We're going to share a video now of Mandy, and Mandy's helping us launch this campaign. So really positive, I think, to welcome Mandy onto this. So just 2 seconds while I share my screen. Make sure we've got sound for you.
Hi, I'm Mandy Rylance. I'm age 60. I'm a mum and a grandma. I've got a son called Sean and a grandson called Lincoln. I work at Buzz Bingo. I'm a deputy
Kirsty.
at Barnsley, and every day I come into work, we have a great time. We look after the customers and love every one of them. On the 29th of September last year, I came to work and I had a stroke. I came to work on that day perfectly well.
Can everybody see that video?
Absolutely fine. Did all the jobs that I needed to do that morning. And at 11:20.
You say you can't see it, Nick?
I can't see it. Can everyone else see it?
Yeah, I can.
Yeah. I can. Yeah.
Yeah, I can.
I've seen it before. Keep playing it.
Okay.
Sorry.
Remember the time clearly as my son phoned, and he doesn't normally phone me at work. I answered the phone, still felt fine, put the phone down, and then started to feel slightly unwell. Not sure what was wrong, just felt unwell. So I thought I needed to go to the toilet, set off to the toilet and wanted to lay down on the floor straight away. I started to feel as though I'd got something wrong with my face, but didn't know what. At this point, I had a walkie-talkie, which I got in touch with one of the staff who came upstairs to my office, and they phoned 999. I didn't think anything was wrong. I just wanted to lay down, and I said I'd be fine. Just leave me 10 minutes, I'd be okay. The member of staff luckily ignored what I was telling her and phoned for the ambulance. The ambulance came, and obviously the ambulance staff knew exactly what it was. When they asked me to lift up my left arm, I couldn't do it. And I knew in my own head that there's something seriously wrong. I got blue lighted to Pinderfields Hospital at Wakefield, not knowing what a stroke's really about, because I've never thought about it other than watching the advert on TV. I didn't expect that I would be having a stroke and didn't know the consequences of a stroke. Once they got me in the ambulance and the blue lights came on, I was petrified. I felt every emotion going. I didn't know what was going to happen. I didn't think I'd survive because it felt so dramatic to me. And then when I got to the hospital and they rushed me straight in for a CT scan, and MRIs and things like that. At that point, I were in bits.
A stroke is most commonly caused by a lack of oxygen to the brain, similar to a heart attack. We sometimes call a stroke a brain attack. The most common symptoms are facial droop, weakness of the arms or the legs on one side, and slurring of the speech. So they can be remembered by the acronym FAST, so F for face, A for arms or legs, S for speech, and then it's time to call 999. This will enable the ambulance service to direct them to the most appropriate place for treatment. If patients arrive at hospital within 4.5 hours, they might be suitable for 2 types of treatment. One is a clot melting drug, and one is a procedure under anaesthetic to remove the clot. Both of these treatments will improve people's chances of surviving the stroke with reduced disability. But we need to get these people into hospital quickly to enable them to have these treatments.
After I'd been on the stroke ward, I was released home, at which point I had the Barnsley stroke community nurses come out to help, and they came nearly every day for a couple of months. The nurses basically showed me how to do exercises to build the strength in my left arm and left leg. I made numerous visits to hospital for the eye clinic and different things to be checked over, which I'm still doing now, and everybody was great. I don't think I would have got back to work like I have done without the help of the stroke team and without obviously the clot busting drug. That was the key to everything: getting to hospital in time, getting diagnosed, getting that drug, and then I'd got the Barnsley stroke team, and they helped every which way they could, every department, and without their support I wouldn't have got this far. But the key to everything is getting that drug. I had that drug that has changed my life.
So Mandy did really well. Luckily, people around her recognised the symptoms that she was having were a stroke, and the ambulance service took her directly to the hyperacute stroke unit outside of Barnsley, where she received the clot melting treatment. And she's done really, really well. Her outcome could have been very different if she'd waited and presented later. We have data to support that Barnsley patients on average will attend 15 hours after the onset of their symptoms. This compares nationally to about 3.5. We know that Barnsley patients are really stoic and sometimes don't want to bother anybody, but obviously the sooner they attend the hospital, the quicker we can put these treatment plans into action and have the best possible chance of the best possible outcome.
I was invited to join the South Yorkshire and Basset Law stroke panel, and I was interviewed for that role, and I was actually given the role, and I'm on now a panel of people. There's about 6 people on that panel, and it's a case of getting everyone's stories together and working with the stroke services to try and get the same treatment for everyone and make people aware of what symptoms are.
Okay, so thank you for that.
Struggling with debts over.
Let's just stop sharing my screen. There you go, you're all back. Thank you, Nick.
Right, so immediate thoughts and reflections around that video from governing body.
Nick.
I'll have to come out and come back in, Kirsty. I think there's something wrong here. I can't see anybody. So I'll come back in if Chris just takes those for me. Okay.
Good morning, Madhvi. You have your hand up. You want to come in?
Yeah, thanks, Chris. So my initial reflections, a really good video comment, basically. And I think it comes timely because we had this discussion when we had the initial audit in terms of stroke and how Barnsley is an outlier. And as well as I think COVID has taken over people's lives for a couple of years and over. And I think although there is COVID, there's everything else that was going off, isn't it really? But it was pretty much sort of everything else was forgotten about. I think this will be a really timely campaign and just sort of making people aware that there are other things that can happen, and seeking help at the right time is so important. And I think it's such a powerful video.
Thank you, Madhvi. seeing as I've got the mic, I might as well put my little penneth in here. I think what's important for the people of Barnsley is to understand that as a governing body, as a clinical commissioning group, we put an awful lot of work into reconfiguring the pathway of stroke from taking to the nearest hospital and not necessarily taking to what we know as a hyperacute stroke unit. It did take us some time, but nevertheless, we did eventually get there. Over that period, quite interestingly, within my own zone of influence, 5 of my friends, family, 5 of them suffered stroke. And to the best of my knowledge, only 2 of them were actually given the benefit of a hyperacute stroke unit in the early days. 2 of them not in Barnsley, but they have been left with certain conditions which maybe if they'd have been put straight into a hyperacute stroke unit, they may not have suffered. So important that as we have innovated pathways for the people of Barnsley, here are the facts in action. Mike.
Yeah, I think it's a brilliant video, and it underlines the benefits of following the science, in that a lot of these specialist services can only be done on scale, and therefore by centralising specialist units actually improves the results in a very significant manner. And the stroke and obviously heart attacks are 2 of them, but there are other ones that ought to be dealt with as well.
Indeed. Dr. Cundley, Ada Cundley.
Thank you, Chris. Yeah, very, very powerful video, and it just demonstrates the success of the reconfiguration of the stroke services in Barnsley and Bassetlaw and West Yorkshire. I remember, probably you two will remember, when these services was being redesigned, there was a lot of, we had a lot of stick in Barnsley from a group of people, and I hope they can actually see this success story of patients, which not only Mandy, I have seen several people in my surgeries, you know, young people with stroke who are out of the stroke unit within a week, up and walking about, only because of the service that have been introduced. So yeah, very good credit to the stroke services.
Any more comments in relation to this? No? Okay, let's move on then to agenda item number 5, which is declarations of interest.
Okay, I'm back. I can take that. You can see me, I think, now.
I can see you.
Right. Thank you. Thank you for your help, Chris. So, declarations of interest, item 5, as the report. Are there any new that anybody wishes to share or update us with? Can't see any hands. That's good. So, can we then move on, Kirsty, to item 6, patient public involvement activity report, please.
Yeah, of course. So thank you, Chair. So I suppose just linking this back into the story that we've just seen. So Mandy's, I just want to say thank you to Mandy, because she's given her time and she's part of our engagement process. So this is about getting people involved and helping shape services. And it's not always about surveys and, you know, and consultations. It's about actually having people with lived experience at the heart of shaping some of those services and giving their feedback on what it's actually like, so we can make some changes. So I think that's a really positive example. So say thank you to Mandy for that. So we've got 4 items just to highlight really this month for assurance for colleagues. The first one, I'll just quickly take us through. The first one that we're right in the middle of now is talking to people about the all-age mental health and wellbeing strategy. So we launched that piece of engagement middle of December. And I think it closes on the 26th of January, something like that. So we've got over a month there where people are now having a look at the strategy, taking it away, seeing if it's fit for purpose. And I suppose one of the things just to flag with this is the mental health strategy has been in development for quite a while. and in terms of patient and public involvement, that's a really good thing, because actually what we've got to a place is where people have been involved in developing it. So we're not sort of developing it in a darkened room and then we take it out and we say, right, what do you think of this? It's actually developed with people alongside them. So at this stage, it's just reflecting it back and say, look, this is what you've told us so far. This is how we've worked it into a strategy. Does that sound about right? And is there anything else we've missed or perhaps we want to strengthen? So I think we're in a really good place with that particular strategy. And I understand that will go back into the Health and Wellbeing Board as well. So it has a much wider view on this than obviously just us within the organisation. So that's the first one. We've also been looking at neuro rehabilitation. So Viv in our commissioning and transformation team has been working with people who've had experience of head trauma. And certain groups of those, and a little bit like Mandy, we're asking them to get involved and help shape the experiences. You know, what are services like for you in Barnsley? Where are some of the gaps? Where are things that we can improve? So that's a really good piece of work that's taking place. And then finally, one of the ones that we'll be bringing back to a future meeting is around again, talking to people about their experiences. So people who have had a referral because of a suspected cancer, or so symptoms where, you know, we would call it a 2-week referral. And actually we're talking to people about what was that like? Did you have enough information? Was the information clear enough? Did you know who to talk to, who to ask? What sort of things were there to support you between that very specific period? And I think we've had about 65 people who've been through that process recently who've talked to us and shared their experience. So we'll bring that back, and I'll have a look and see. That might be something that we can perhaps work into a patient story or somebody's experience, because I think actually that might bring it to life quite a bit. So they're the 3 ones that we're currently working on. And then what I've also included in the report, and it just adds to the paper that we've got later, is some of the work that the South Yorkshire Cancer Alliance are doing. And actually they've got a whole suite of people that are helping them and helping them shape services, both in Barnsley and across South Yorkshire and Bassetlaw. So it's just to give you a flavour of some of the work that's happening there, because we might not always see that when it's wrapped up in a big assurance report. So that's my update for this month, Chair.
Thank you. Any questions for Kirsty on that patient involvement report? No, thank you, Kirsty. So item 7, I understand there have been no questions received from the public on governing body matters. Okay, can we then move on to item 8, minutes of the meeting of the 11th of November? And they're here just to for any clarification that might be necessary, but for approval. Are people happy to approve those minutes? Okay, that's good, thank you. So we move on to item 9, the matters arising report. Anything anybody wishes to pick up on that? Most of it's complete. In the previous meetings, there's 191103, which was, we were giving some consideration to involving the voice of younger commissioners in some of our work. I think because of COVID and other things, that slipped quite a lot. And I would suggest at this moment in time that we close that action and leave it to the new place-based arrangements that will come after the 1st of July, and they can pick that up if they feel it would be valuable. Okay, thank you. Is there anything else on matters arising? No? Okay. Can we then move on, please, Chris, to item 10, Chief Officer's report and the planning guidance. Thank you.
So, sorry, I just went back onto mute. Thank you. And you just preempted the announcement around the 1st of July there. So, the key thing in the 2 things in the planning guidance that came through. So the planning guidance came through on Christmas Eve at 4 o'clock. As it does, and there were 2 key things. We were given an announcement that the formation of the integrated care boards, which was planned for the 1st of April this year, will be delayed until the 1st of July this year. The rationale for that was around getting it through the parliamentary timetable. So the bills had over 300 proposed amendments in the House of Lords. that need to be worked through. It was recognised that obviously the Omicron wave was affecting the NHS, and doing transition at this time would be difficult. So the pragmatic solution was to delay till the 1st of July. The intention for us as a governing body is to continue our governing body until the end of June to ensure smooth transition to the 1st of July for the formation of what will be called the South Yorkshire Integrated Care Board. Just a note to that, in terms of we're currently South Yorkshire and Bassetlaw, the plan is for Bassetlaw still to do the boundary change to Nottinghamshire on the 1st of April. So we'll become South Yorkshire rather than South Yorkshire and Bassetlaw on the 1st of April. And then we'll transition 1st of July from 4 CCGs to 1 South Yorkshire Integrated Care Board. The other thing that was in the guidance was 10 priorities. I'm just going to quickly just take us through them, just the headlines on those priorities. So the first one was investing in our workforce. It's the continuation of the expansion of primary care, mental health and community services, and also looking at new ways of working, and also looking to try and strengthen the compassionate and inclusive culture needed to deliver outstanding care, which we all aspire to. The second priority is responding to COVID-19 ever more effectively, and that's about treatments for COVID and ensuring the rollout of the vaccination programme as it evolves over time. The third priority was tackling the elective care backlogs. We were doing pretty well before the Omicron wave and tackling the backlog, but obviously that'll set us back a bit because we have had to cancel elective work during this wave. So it'll be an absolute priority to tackle long waits and improve performance against cancer waiting times. The fourth priority was improving the responsiveness of urgent care and building up community care capacity, keeping patients safe and making sure we get their care in the right time in the right setting. The proposal is to have 5,000 additional beds nationally, and that's through expansion of virtual wards and with the intention of eliminating 12-hour trolley waits in our A&E departments and minimising ambulance handover delays. The fifth priority is improving timely access to primary care. So this is talking about investing in primary care, developing primary care networks to expand capacity, increase the number of appointments available to our patients in Barnsley, and to drive integrated working at neighbourhood and place level to try and increase access. Next was the continuation of improving mental health services for people with learning disabilities and autism, and maintaining the growth in mental health investment, which we've successfully managed in Barnsley over the last couple of years, and just to keep that absolutely as a priority, and to transform and expand community health services and improve access further. The next was continue to develop our approach to population health management. We've done population health management for years, but this is becoming an absolute priority in terms of everything we do. So it's focus on prevention, addressing health inequalities, and trying to increase our use of data and analytics to redesign care pathways and measure outcomes with a focus on improving health and health inequalities. I mean, that's continuing everything we've done over the last few years and trying to really up the ante on that. Next is exploit the potential of digital technologies. Obviously, during the pandemic, we have exploited digital technologies, but it's about locking in that learning and making sure we complete the pace of transformation in the digital agenda to improve patient access, patient experience, patient outcomes, and achieving a core level of digitisation in every service across systems. Two more, so just to make the effective use of our resources, obviously it's public money, we are custodians of taxpayers' money, so we need to make sure absolutely effective use of resources, moving back to beyond pre-pandemic levels of productivity when it allows, and make sure everything we do offers efficiency and value for money. And then lastly, to establish our integrated care boards, ours will be South Yorkshire Integrated Care Board, and collaborative system working, so that will be across health and social care in the Barnsley place for us and across South Yorkshire, working together with local authorities and other partners across the ICS to develop 5-year strategic plans for systems and places, and they'll need to be developed for March 2023. So I'm just going to pause there, see if there's any questions, Chair, just before I finish off, if that's okay. So I've been through quite a lot there. I think I've got Chris.
Chris.
Thank you, Chris. For the people of Barnsley, yes, it's quite a long list there, and we all understand the list. But for the people of Barnsley, I wonder whether you could just spend just a few more minutes explaining elective care, because people don't always understand what elective care is. And in fact, the backlog, you know, we know there are backlogs and we know it's in elective care, but I'll say again, people don't always understand the word elective. And I did make a commitment to someone quite important to me at one stage through Barnsley Patient Council that we get rid of some of the jargon bits.
Yeah, I agree, because I've always preferred the jargon planned and unplanned. I think it makes more sense. So elective is planned. So if you get an appointment, you go through a pathway, you go to your GPs to get diagnosed, you get a referral to hospital, then you get a date for operation. That's a planned elective surgery. If you come into A&E and you need urgent surgery, then we call that non-elective or unplanned surgery. So that's the key. In terms of tackling waiting lists, it's in some ways it's easier to tackle planned surgery, because obviously we can put on extra sessions and have planned appointments, we can do weekends, evenings, that sort of thing. So that's what we'll look at. And also the key for that is looking across South Yorkshire. So whereas we may have extra capacity in Barnsley, we may treat Sheffield patients or Rotherham patients or vice versa. So it's looking across the system on the planned surgery to make sure we use all the capacity in South Yorkshire to make sure everyone gets the best possible deal.
Thank you, Chris.
John?
You're on mute, John.
Can we just look at the digital agenda? Because after the first bout of COVID, everyone was enthusiastic about e-video consultations, in fact, emails, etc. Said it worked well. And then we found that patients were complaining, unable to get through to their GP, not seeing face-to-face. My experience is that patients want to be seen face-to-face, and I think we all probably would agree to that. Ourselves, I don't know about my other colleagues, but secondary care are still doing telephone consultations, and the additional work then is passed on to primary care. Could you do this? Could you do that? So I'm not convinced that digital care or agenda is going to work for patients. Especially, well, we had the tabloids complaining about GPs not seeing patients and all these video consultations. So I'm not convinced that that's the right direction to go. Politically, it will change.
Can I respond to that, John?
Yeah.
So I agree. I think when we speak to our patients, we get a mixed response. So some patients love the digital world and digital agenda and the easy access it offers. But some patients prefer face-to-face contact. And I think our job is to make sure we have a mixed offering to make sure we meet everyone's agendas. But there is a caveat to that, because we are going to be living with COVID now going forward. And it may be as infection rates go up and down, we may need to err towards digital approaches when infection rates are high. We may be able to expand face-to-face when they're not. So I think it's about coming up with a middle ground, John, rather than just a one or the other.
So we also put ourselves at risk medical legally, because a lot of cases that GP did not see the patient. Prescribing telephone without seeing the patient.
Okay, can I come in on that? Because number one, the GMC did publish some guidance during COVID that they would support clinicians who were trying to limit transmission of COVID by not seeing patients face to face. Secondly, it's a fascinating discussion because, and I hope people at Barnsley have listened carefully to what John and Chris have said. When the NHS, so my view is when the NHS was set up in 1948, we had no option but face-to-face consultation. So we accepted that as the gold standard. What COVID has taught us is that there is an appetite and a rationale for not seeing all patients face-to-face. In fact, some find that they can get access better and at different times of the day through a phone call rather than necessarily a strict appointment. So there are new ways of communication, and we have to harness those and try and give the offer that people want and find comfortable to different parts of the population. For myself, I don't think face-to-face is any longer the gold standard. And each time I see a patient face-to-face, I have to ask myself, what is that adding over and above them sending me an iPhone picture or me arranging investigations before I see them, or a telephone call, or recognising immediately that I'm not the person to help them and that they need to be referred to see somebody else. So increasingly, I think doctors are asking themselves, there is something about the traditional mode of face-to-face consultation, but there is also a question for us always about what it adds, what's the added value of face-to-face. And for some patients it's a lot, for some it's not. And I think in terms of managing capacity and satisfying access and patient satisfaction, I think there are a range of ways of communicating with patients going forward. So the push to go back to all face-to-face is a little bit emotional, it's traditional, but it's also a little bit irrational in view of the digital ways and other ways of working that we have and that COVID has accelerated. So I'll pick up Jane and Mike now. Jane, please.
Okay, thanks, Nick. So I'm just sort of picking up on the first priority, so invest in our workforce with more people, which obviously is absolutely the right thing to do, you know, because that underpins the rest of most of the other priorities. But we also need to be investing in our workforce with regards to health and well-being. You know, we've got an exhausted workforce across health and social care. Yeah. So, you know, we need to be making sure that our providers and, you know, partners have, you know, strong policies, strong plans in place to ensure that they are looking after this, you know, the staff's health and well-being. It's so key.
And that's really important because we can't afford to lose the people we've got because we need so many extra, and it's not going to happen quickly. That's my reflection on this, Jane, because it's not a question of money even, it's a question of having people that are willing to train and the lag that is in them getting trained up and then supported and then them choosing which jobs, which parts of the system they go into. So there's a whole range of factors. So we need to preserve what we've got and add to it. But if we don't preserve what we've got, we're going to be continually trying to add. And I think we're chasing a losing game there. So I think you certainly need to preserve and support the existing workforce as much as we possibly can. Mike?
Oh, well, Jamie had his hand up before me, but he's taken it down. I don't know if he still wants to talk.
Jamie?
It were only a point, Nick, just around the digitisation bit, and I think, you know, there's two elements to that, and one is around the model for direct patient care, but the other bit that's included in the guidance that I think is really important that can help us to deliver better patient care is digitisation that helps us with population health management. So shared care record and the access to that shared information that helps us with things like the tell it once message, whereby, you know, we're getting feedback still that people have to tell the same story through a number of assessments. So I think some of that stuff is really important, and that's included in there as well, and obviously has been a priority for us in terms of sharing our information across Barnsley for a little while now.
Yeah, I think that tell it once, I think Chris brought it up in previous governing bodies and meetings. People get exhausted, especially when they're ill, retelling the story several times and then waiting somebody to respond to that, which they could have prepped up on very quickly in a few minutes before they see the patient at that juncture. Mike?
Yeah, I mean, mine's in a way an extension of that. I think I've been quite disappointed. I mean, we're still locked in the idea if we have to do consultations, whether it's face-to-face, online or what have you, but an awful lot of now with artificial intelligence, there is the ability for patients to actually move their care on without actually seeing a doctor. And there just seems to be a total inability. I've been involved in 1 or 2 SYV work streams, which seem to reach the point where we need to take a leap of faith forward. And yet they don't do it. They go back, oh, it's calming down, we'll go back to face. And there's a lot of evidence that if patients do this, find relevant online education, they can actually save themselves going to places. And the other part of this is, you know, how people operate. And I mean, a relative of mine has taken 6 months getting onto a waiting list. And the first appointment for which he waited several weeks, they said, oh, it's all in the letter, yes, we'll arrange a scan. the next appointment, because you waited another 2 months, it was, oh, the scan means you need referring to other specialty. And the third appointment was, oh yes, the scan shows you need this form of treatment. Well, why did you wait all those times when the answers were actually in the letter, on the scan, and on the results of the scan? And if people could only break the system down, it's almost as if we have this thing of you have to see the patient before you can actually engage your brain. And if this system could change so people did it much more proactively, you could actually, people talk about manpower shortages. Well, if people are doing, in that case, 3 or 4 unnecessary consultations, I mean, that frees up an awful lot of manpower time. And I think the NHS has to grasp this idea we're now in the 21st century, no longer doing Dickensian things where people sit and wait and see people. An awful lot can happen online, and a lot of that care can be used using artificial intelligence, can actually drive that forward several steps before they actually see somebody. So that's my rant of the day.
Okay, and entirely appropriate. Chris Millington, and then Dr. Addy Cunley, and then if there's nothing else after that, we'll move on. Chris.
Yeah, it's like anything in life. You're only interested when it affects you, and we have a situation at the moment, as you know, where it's affecting my family, and we are in the situation whereby we are getting monthly telephone consultations, and we're glad to have them. What it says to us is someone still cares, and it's all over and done with within 10 minutes. The last telephone consultation, the consultant said, right, we want to see you face to face. My reaction was, why? Everything's progressing beautifully. You know, what it means for us as a family is that we've got to drive all the way down to Sheffield in the early rush hour traffic times, not so much rush hour now, but to me, that consultation could be a Zoom meeting, it could be a team meeting, and it would stop us having to drive all the way down to Sheffield. We're going to get down there, and within 15 minutes, the consultant's going to say, yeah, we're quite happy with that. Thanks for coming. So there's like anything else, you know, this situation we've found ourselves in over the last 18 months or more is totally unique. But what it does is it forces change, and I think the change that we are looking towards in relation to digital, whatever things you might want to hang on to digital, are the right way to go.
Yeah, so thank you for that, Chris. And so in terms of my contribution, the question that you're asking there is, what's the added value of that face-to-face?
Correct.
And what's the inconvenience or discomfort to the patient,
correct,
family, and what extra in terms of changing the management and better management is going to occur? Sometimes it will, sometimes it won't. But so to my point is, for every person that we see, we should be asking, what is the face-to-face going to add? And if it adds something, great. If not, how else can we manage it in a way that they may be satisfied with? So, Debo, you've been patiently waiting.
Thank you, Chair. I mean, for all of us here, we are probably on the higher end of things where we are very used with this digital technology. For a lot of our patients, they will still prefer to come to the GP surgery, and it is how we manage that for them, really. So it's going to take a while. We should still encourage this, but we should not be surprised where a lot of people, because we as GPs, we got a lot of how would I say, anger in the mass media because we were not seeing people. Not because we don't want to see them, we would like to see them, but they don't need to be seen. And that information, transferring that to the public is still a bit challenging. And most people really, for instance, where I work, they will still prefer to come to the surgery, even for the simple cold, for the cough and things like that. You ask them to go to the pharmacist, they don't want to hear that at all. And you speak to them over the phone and say, well, how do you know what's wrong with me when you've not seen me. And that's because of the way we've done things traditionally. And this is a big change for a lot of people. So we will need to be patient, but we should still continue to drive it forward, this digital technology.
Okay, thank you, Devo. And of course, you're quite right. We're at the higher end of tech usage. Not everyone is, and they get reassurance from what they know and understand. And this is going to take time, but I think it's going to be a mixed model that comes forward to satisfy a variety of needs. So we'll have one more point from Chris, and then we'll move on.
Just one final point, and to put this into context, that I can't see my doctor, and I get this through patient council. From April to November, we have seen, or you, the clinicians, the GPs, have seen 655,391 people face to face. So the sad part about it is people who've been given appointments failed to turn up, and that figure is almost 40,000 people. It was 39,709 people who failed to turn up. Makes you think.
Okay, so I think the governing body has given very healthy and diverse attention to the planning guidance. Was there a final thing on your report?
Let me just finish off, if that's okay, Chair. Let me be quick. So just the last thing was on the our Better Care Fund. So our Better Care Fund is a budget we get across health and social care, which we agree with our colleagues at Barnsley Council. And basically, we've submitted this up to our NHS England, and they've approved our plan as being in line with good practice, and has been formally signed off, and the funding's being released for us to invest the money in services for Barnsley people. So, Chair, that is the end of my report.
Right, so as I say, thanks, Chris. We've noted the priorities and operational planning guidance and the Better Care Fund position, and encloses the letter that we've got approving our arrangements. So thank you, governing body. So can we now move on to item 11, COVID-19 response and recovery update, please, Jamie?
Yeah, thank you, Chair. And it feels a little bit strange sort of looking at this report, having sort of seen what came out on the news yesterday, and the pace at which things move. However, I will take you through, and I'm going to share as we come on to the guidance that came out, the slides, and probably use them just to highlight the things that we've done over the last month or so to support health and care services, and particularly primary care, with the vaccination programme, because some of this guidance will now start to become less relevant as things change. So in terms of the position, we're nearly 2 years in now since the March announcement of a global pandemic. However, in December this year, based on the increased sort of transmissibility and increase in infection rates, particularly in terms of the Omicron variant, the government did make a decision to step us back up to level 4. So they're the national alert levels, which identifies that the pandemic is in general circulation, transmission is high, direct COVID-19 pressure on healthcare services is widespread and substantial. And I think through December, that absolutely felt like where we were, all of our health and care services absolutely under pressure and feeling that. We saw a big increase in the infection rate. So again, this is obviously at the time of writing the report, and the period I'm reporting is up to the 3rd of January. The 7-day all-age incidence rate had increased to 2,125 per 100,000 people. So a significant increase, and actually 130% increase from the previously reported 7 days. And there were also an increase in over 60s. So the rate there was 1,200. So we'd seen that increase significantly through December. It is probably worth just noting to governing body members and for members of the public that has now started to reduce, and the latest figures that we've seen are closer to 1,500 and 800, which is still hugely significant and much higher than we were seeing in the early part of the pandemic, when we were looking at introducing restrictions when the rate reached 50 per 100,000 population, for example. So that's where we're at, and that equated in that week to around 7,000 new cases, so significant numbers in our population who were infected with COVID. That obviously has a knock-on impact, so hospital cases rising, and that's continued since Christmas. There's been over 80 positive inpatients at points. That continued to rise. It has started to level off now and reduce a little. Most are over 50, or most were over 50, vaccinated and in hospital, but for reasons other than COVID. So people who were testing, and so it was more the community incidents. What we did see, not necessarily in Barnsley, but generally, is those who were in critical care, significantly higher proportions who were unvaccinated as opposed to vaccinated. So those that were becoming seriously ill tended to be those unvaccinated. And then just in terms of that vaccination programme, I think we talked, but we might not have, I'm trying to think of the timing. So when we come on to the guidance, I'll cover this, but we were asked to step up significant amounts of capacity. We did that. We increased capacity for vaccination by establishing a large-scale pop-up walk-in facility at Barnsley Metrodome, and that's meant that we can take the booster coverage now to it's above 90% for over 70s, approaching 90% for 60 to 69s, and it's around 75% now for 50 to 59s. There's still quite a significant amount of the population who require their booster, and it is also worth pointing out that in Barnsley there's still over 30,000 people who are eligible for vaccination who have not been vaccinated at all. So we'll continue to work on that. I shared with governing body members a number of sort of attachments, which, you know, I know there were a lot in there, so I'm just going to share my screen quickly and take you through the key points of them and note how that impacts on us, if that's all right.
Yep, thank you.
Are people able to see that?
Yes.
Yeah, thank you. I can't see anybody now, but I'll take you through. So the first thing to note was, obviously, on the 3rd of December, the JCVI advice in response to the Omicron variant and the increases. So the ask coming out there was to expand the booster programme. Previously, it were for 40 years up. So expand that to all over 18-year-olds, to provide a 4th dose for immunosuppressed individuals. So the primary dose of vaccine for immunosuppressed is 3 as opposed to 2, but increase that to 4 and offer that 4th. Increase capacity through PCN-led vaccination services, which we did significantly at Priory Campus, Apollo Court and Goldthorpe, by putting additional appointments on, but also opening up the Metrodome facility with the support of partners. Increase capacity through PCN-led, sorry, I covered that one, that's the vaccination, but to support that, sorry, income protection was muted around minor surgery days, and I'll come back to that. Deferral of routine health checks, amendments to QOF and amendments to the PCN. So the government were noting there would be a need, if we're going to step up this capacity, to support that. There was an increase in the payment for vaccination to make sure that capacity could be secured, and there was information around pausing routine CQC inspections, so things that would help us step up that capacity. So just after that, we then had confirmation of the temporary changes that would help our GP practices and PCNs to release capacity to support the programme. That was around, I wouldn't say suspending or pausing QOF and IIF activity, because I think everybody recognises how important some of that was, but recognising that if primary care are prioritising vaccination, that some of the targets set out may not be achieved. So it were about making sure that practices receive the income to be able to continue to support that and to continue to deliver QoF care wherever possible, and also the areas of the IF. But there were a specific ask to focus on the 4 vaccination and immunisation indicators that are included in QoF. There was income protection for some of the others. So some of this was around indicators around maintaining registers. There were some prescribing areas that if we didn't achieve the targets, we would still receive the funding, and undertaking some fairly routine health checks. So where people require an health check every 12 months, where it's clinically appropriate, permission to sort of pause or slow that down to allow that to work through. To receive that funding, practices did need to agree with the Commissioner how they would re-establish care and make sure that wherever possible we would continue to deliver that, and practices in Barnsley have all done that. Our primary care team have been working with them to do that. And then the Impact and Investment Fund, similar basis, certain indicators which were identified as still being funded on delivery. So that were mainly around immunisation, but also the categorisation of GP appointments. And then the other indicators, which would have included things like numbers of referrals to social prescribing, ensuring that care home residents have a personalised care and support plan, structured medication reviews. While still important and still being pushed on, the payment for those indicators was repurposed to provide a PCN support payment, and also a new indicator which was to encourage all practices to sign up to phase 3 of the vaccination programme, which in Barnsley they did. So that's a positive. Just quickly through the next couple. So then there were a system letter, obviously confirming that we'd moved to level 4 and setting out the expectations, and there were 6 areas. So first, which we've just sort of covered, were around ensuring ramp up of the COVID-19 programme. Second was around availability of COVID-19 treatments, and we've seen the introduction of the new medication for people at risk of COVID and people who may suffer more as a result of having COVID than others. So that's been provided in the hospital. Maximising capacity across acute and community settings to make sure that we've got timely discharge. So there's been a lot of focus on discharge, making sure that pathways are strong, that where needed, additional bed capacity is in place. Barnsley, as we've reported and talked through previously, have been in a really good position in terms of discharge, but have been quite challenged over this last month or so, mainly due to staff absences, but also the number of outbreaks across care homes, which limits the number of beds that are available to support discharge. Supporting patient safety in emergency care pathways and managing elective care, supporting staff and maximising their availability. So this were about freeing up staff time to be focused on the priorities, and there was a process to review and establish surge plans, which we did with our partners over the sort of last bit of December to support us through January. Then also on that day, further, which again was aimed at primary care, next steps for the vaccine, and there's nothing new in here. This confirmed what had come in the earlier. So everybody over 18, create capacity, increase workforce, action to increase supply. So there were changes made to the supply chain to make sure that any sites could get access to the vaccine that they were required, and funding if needed for estates, and obviously finance where they'd guaranteed programme budgets to cover costs. So that's where we were at on the vaccine programme. We've seen some changes a little bit since, so we've now moved to 12 to 15-year-olds, and there's going to be the introduction of vaccine for 5 to 11-year-olds with underlying conditions from the end of January. So we're just working through that process. We then got some guidance on Christmas Eve, as well as the planning guidance, which was around reducing the burden of reporting, releasing capacity. Early in the pandemic, we had similar, which talked about how we use our meetings, governing body meetings, provider meetings, others. There were nothing really new in there, but just confirming that flexibilities were still in place around things like quoracy and other things of meetings to make sure that we can keep business going, but allow people who are particularly front-facing to be delivering care to patients. So they came out, and then I hadn't shared this, but I just wanted to flag this to governing body members. It came out after all of the papers, but we should all be aware of it. So legislation around vaccination as a condition of deployment. So all individuals who are undertaking CQC regulated activity or deployed to undertake CQC regulated activity must be fully vaccinated by the 1st of April. That includes clinical and non-clinical staff who may come into contact with patients. So in primary care, GP practices would include receptionists who are front facing. In hospitals, it would include people like ward clerks. People who are totally back office and don't come into contact with patients are not included. It applies to both public and independent sector, so it applies across all of our care sector. So it's really important to us. The legislation came in the 6th of January. It allowed a sort of period of grace up to the 3rd of February for people to get their first dose. The reason that's the 3rd of February is that is 8 weeks before the 31st of March, which is when they would be eligible for a second dose in order to continue to work in them front-facing roles. And there's lots of guidance around how to support members of staff, resources around supporting them to take up the vaccine, but also guidance around changing roles, how you can reconfigure, redeploy, etc. And then just to confirm, the coverage is all staff who are deployed for the purpose of providing CQC, with the exception of workers who don't have face-to-face contact, not included. Workers under 18 are not included. There's a typo on the next line, but workers participating in a clinical trial for a COVID-19 vaccine. Workers who should not be vaccinated for medical reasons. And there is a process and an application process through 119 to apply for medical exemption, should that apply. And workers who are pregnant and have a temporary medical exemption, that's through the same process. And that would be, whilst we encourage people who are pregnant to have the vaccine, there can be a temporary medical exemption, and that's valid to 16 weeks following birth. Everybody else is included. And we've had a meeting this week with partners across the system, including hospice, primary care, hospital, community services, social care, and are assured that everybody is on with this, have got processes in place, are working and supporting their staff to access the vaccine and make sure that we're in a position from 1st of April to be still delivering our strong services. So I think that takes me to the end, Chair, so I'll stop there and I'll work out how to unshare. Thank you. I think that's done it.
Okay, that's done it, yeah. So thanks, Jamie. Do we have any questions? Things are changing very rapidly with COVID.
Yeah, I'll be telling you something different next time, but we'll work through what the changes that come from yesterday's announcement mean in terms of all the different aspects over the next week or so.
Okay, so are there any questions that anybody wishes to ask Jamie? No? Okay, thank you. Thanks, Jamie. So can we move then, please, Jeremy, on to item 12, integrated care at place and health and care plan update.
Thanks, Chair. So just wanted to give a governing body in public a quick update of where we are with the Barnsley Health and Care Plan. It's been a governing body a couple of times, so I think you're probably familiar with the content in it. Chair, I've got some slides. They're in the pack as well. Meeting in public, it would be helpful to just put the slides up and just talk to those so people can see the content as I go through it. Is that all right?
Yep, that's fine. Yep.
Can people see that?
Yes.
Brilliant. Okay, so update on the plan. As governing body members will remember, it's a one-year plan. We developed it last summer. Seems like a very long time ago, given all that's happened. And we had 25 priorities in that plan for us to work on. And it's important to remember here that the plan isn't the totality of everything all organisations are doing in Barnsley. This is the plan that focuses on what we want to do collectively together as a partnership in Barnsley. So work has continued on the mobilisation and delivery of the plan. Obviously, the operational impacts of COVID have meant that certainly over the winter period, we've had to scale back the pace of progress and change. And we asked all the senior responsible officers for the who chair the programme boards just to go through the priorities and really be clear about the ones they felt they wanted to, were able to continue to work on over that winter period. And that's been done, and we now have a programme management office, a PMO, in place that's overseeing that work. And there are senior responsible officers for each of the programmes, programme managers for each of the programmes, and defined priorities and milestones for each of those programmes. And as governing body will be aware, that programme management office is then managed in our partnership forums. So it's managed at our integrated care delivery group, which I chair currently, and then reports through to our integrated care partnership group as well. So a lot of progress has been made. Actually, when you look at the totality of the plan and the priorities and the pieces of work that are happening within it, it's really quite substantial, even though we've had to scale back our ambition a little bit. One thing that's probably worth saying at this point as well, I'll pick it up in the next steps towards the end, but it's worth saying up front, I think, is this was a one-year plan. So it takes us to April 22. Clearly, we now need to be in the process of refreshing it and revising it. So we have a one-year plan for 22-23 as well. And as I said to governing body and development session a few days ago, I'm hoping that we can get some real engagement and participation from governing body members over the next month or 6 weeks as we refresh that plan to make sure that we're happy with the priorities that we'll then commit to delivering across 22-23. So I've got the strategic deliverables up. You can see the ranges of work and the sort of programme boards that oversee each of those. If you go back to the conversation we've just had around our planning guidance priorities, the 10 of them, you can see there's a lot of reflection of that in the plan that we currently have. Not expecting this plan to change substantially in 22-23, but I do think we need to take the opportunity to refocus us. So I was really interested in the conversation around digital earlier. I think there is an opportunity for us to take some real steps forward in that over the course of the next year. We've got a kind of national priority for us to have a shared care record in place by March 23. We've got a digital team in our integrated care system, and we're now committed to the implementation of the Yorkshire Humber Care Record and all that implies, but it gives us a clear route forward for the delivery of a shared care record in Barnsley. That's been brought into now by all our health and care organisations, including the local authority in Barnsley as well. And we are just about to appoint, just shortlisted, and hoping to get a point from that shortlist of good candidates, a programme manager for Barnsley Digital Group to assist us in that work. That'll be the shared care record, and I think there's another key opportunity for us, which is to come up with, for the first time, actually, a digital strategy for Barnsley, which can take into account some of the feedback from governing members earlier, actually, in terms of setting a direction for us for the future. All of the programmes have some key milestones set out. Got a couple of pages of them here. So on the left-hand side are the programme groups that meet on a regular basis: urgent emergency care, planned care, which is elective, care close to home, which is our out-of-hospital coordination, Better Lives, which is local authority-led, but is firmly within the partnership structure. Mental health, where we have the mental health partnership as well, but it's fundamental to everything that we do, so we review the progress of that in our partnership structures. Ditto with children and young people, and then we also have the community vaccination. And there are also programme groups for all our enabling groups, workforce, estates and digital in particular amongst those. Many of those are on track in terms of the deliverables that we've prioritised over the winter period. You'll notice that we have kind of red, amber, green ratings for each of the programmes, where it's green for delivery. Clearly, we think it's on track for the milestones we've set at the moment. All our finance RAGs are currently rated at risk, and that's because over the course of the last 20 months, we have been operating under a different financial regime, so we haven't had to focus on efficiency in the way that we would have done almost always prior to COVID. As we move into 2022-23, I'm expecting that to come to the front and us to really have to focus again on the efficiency that these programmes can deliver, as well as the better outcomes that we expect them to deliver as well. So we'll have to revise and refresh our arrangements for dealing with that, our QUIP programmes, as we have called them in the past. So the Programme Management Office, the PMO, has mobilised, and I think it's important to think that although we've been under a huge amount of pressure over the last few months, people always like the opportunity to think about what comes next as well. And sometimes, as chair of the Integrated Care Delivery Group, I've had to encourage our senior responsible officers to kind of lift their heads a little bit above the day-to-day, and actually the programme managers in particular really enjoy the opportunity to come together and think about what comes next for their services. So there's quite a lot of energy in that group actually at the moment, and I'm really keen to push that forward. And recognise again the point our Chief Nurse Jay made about the well-being of our staff and the pressure they've been under. You need to recognise that, but also recognise the opportunity that we're going to have as we move into the summer period to really start to pick up the pace on some of these pieces of work. We've been in a COVID situation now for, 22 months. We know next winter is going to be challenging as well. So we will need to maximise that summer period. And in order to do that, I think we'll probably have to look again at those priorities and which ones we think we absolutely must move on to put the maximum energy into those to push them forward over that summer and autumn period. In terms of next steps, we need to refresh that 21-22 plan and make it fit for purpose of 22-23. Really want to take the opportunity to continue to work with governing body members to get your input into that process. As we move into the new organisational structure in South Yorkshire from the 1st of July, there's a requirement there for the Integrated Care Board to have a 5-year plan refresh, which needs to be complete by March 23. I would anticipate we'd start work on that in the summer. And again, I think there's a real opportunity for us to make sure we are engaging, understanding and learning from past work in terms of engagement, but also future engagement activities with patients and the public to make sure we are hearing what they think are the top priorities for them as well as we seek to refresh that 5-year plan. And I'm hoping that now we have an extension to governing body to the end of June, that we can start to bring some of that thinking and the process for that back to governing body. So you're brought into that process, and I hope to maintain your interest as governing body members, particularly the clinical members, into the future to help us continue to develop those key pieces of work. So that's just a quick run through of the plan. The plan is the sort of core of our integration activities for Barnsley, and at that point, Nick, kind of open for questions from colleagues.
So finished on an optimistic note. Any questions for Jeremy? No? Okay. Thanks, Jeremy.
Pleasure.
I think some people might need to switch mics off. Perhaps they've done so because there's a bit of an echo there. So we're joined now by Siobhan. Thank you, Siobhan, who's going to present item 13 for us, cancer assurance report and an update on the diagnostic hubs. Thanks, Siobhan.
Thank you, Nick. Just to say hello, my name is Siobhan Lenjanowski and I'm the Commissioner Lead for Cancer. So I'm presenting this paper this morning on behalf of Dr. Kadarsha. Unfortunately, can't be here today, so he's requested that I do this. As you can see, this is our 6-monthly assurance report, and there are a number of priority areas that we want to bring to the governing body attention just for assurance. So as it outlines in the paper, we're restoring the 28 days faster diagnosis. So what that means is that when you get referred from a GP for a symptomatic cancer referral, we will try to give you a diagnosis whether you've got cancer or not within 28 days. And that's a major target and priorities that we're trying to achieve. In relation to that, we're still having some issues about meeting that target, but we've got a number of improvement programs in place that will help us to achieve it over the next 6 months. Some of that is about we have got cancer navigators coming into place that will help us to speed up the process actually within the hospital to make sure that patients know when their appointment is to come for their diagnostic test, but more importantly, that there's no challenges across that pathway to make sure that the person is able to get that diagnosis within 28 days. We're continuing to run extra clinics as we have been doing across the hospital for the last 12 months to 18 months during the COVID pandemic, to be able to then make sure that we can get people into the clinics as quick as possible and then get them to know if they've got cancer in 28 days. So we are confident that putting in a really robust plan and the number of improvement initiatives that we as a CCG and with the providers have agreed together via the Barnsley Cancer Steering Group, that over the next 6 months we will go from 65%, which is our current position, to 75% to meet that faster diagnosis. All being well if the COVID situation doesn't put us off track again, but we should be able to meet it. We've also got really robust assurance processes in, and what I mean by that, we've got for each of the pathways which are pressurised at the moment and are not meeting 28 diagnoses, which lower GI is one of those. We have got a self-assessments in place and project plans based on that, with really defined actions to make sure that we change the self-assessment RAG ratings to green, which will then make sure that we do meet that 75% target. And that is that's assured, and assurance comes through 2 groups through the Barnsley Cancer Steering, but we also have a specific subgroup for the faster diagnosis and cancer diagnostic, rapid diagnostic area of work, which a number of the governing body do sit on. The other area that we talk about in the assurance paper is minimising harm to patients due to the COVID pressure. And this is something we've been working on as a cancer programme right from the start when COVID hit, and that's minimising the impact of COVID on the cancer pathway. So, for example, we have made sure that we're clinically prioritising all the referrals that are coming in for those who may be symptomatic and suspected cancer. We continue to do that as a system, but the provider at the hospital will clinically prioritise all referrals that come in. And when we say clinically prioritise, we mean that those who need to be seen as soon as possible, those who can have a diagnosis as quick as possible. We've got triage in place to make sure patients know that they need to come to the appointment as soon as possible. Also, we are clinically prioritising all those people who need treatment as well. And this is and one of the ways that we are clinically prioritising is bringing quality of life factors in, indicators which before the pandemic we didn't clinically prioritise on factors. So I wanted to assure you as a governing body, if you're a carer and you're on a referral and you have gone past or are approaching 62 days since you had your referral from your GP or anywhere near that, we will prioritise carers to make sure that they can continue to care for that person. So that's something new that the hospital has never done, is actually prioritising clinically and minimising harm based on quality of life indicators as well. And we have processes in place and tracking systems to be able to assure us for that. The other thing for minimising harm to bring to attention, which the paper talks about, is there are a number of pathways where we've seen less referrals compared to pre-COVID. That's head and neck, lung, and also so there's those two. There's one more, but I can't just remember it. It'll come to my brain in a minute. Bladder, women's bladder, that was the one. And what we're trying to do there is we know that they're lower numbers. And the reason we know is because we collect referral data, we keep an eye on it. And we know at the moment those referral rates have not come back to pre-COVID. And what we're doing there is doing some really targeted communications to encourage people to come, if they have any suspected symptoms, to go to their GP. And lung has always been an issue for us, but as I'll go on to later in the paper, I'm going to talk about the targeted health check, and now that will help us as well in the future. So the other bit we're doing is lots of targeted communication with our comms and engagement leads across Barnsley about targeted communication to people to come forward if they're worried about coming forward because of COVID transfer coming into services. We're doing lots of behavioural insight work, which some of the governing body will know about, where you actually you try to understand why people don't come forward and use those motivations, those targeted messages to get them to come forward. And that's having a big impact already. The next bit in the paper is responding to the decrease in referrals and diagnostic. And as outlined in the paper, we've seen a big referral increase, but the hospital is really responding to that, as I said before, because we've got additional clinics on in a number of places. We've introduced some new staff onto the pressurised areas. So we've got a nurse-led flexible cystoscopy and prostate service where we got some extra additional funding from the Cancer Alliance to be able to then bring that extra resource in to reduce the backlog and reduce the pressure on that referral pathway. We've also got GP practices that are at the moment with the hospital are just trialling and piloting whether a healthy breast clinic for people with breast pain who've been referred down the 2-week suspected cancer pathway, whether if we triage them, would they need to go to screening, and we're closely monitoring that because that's a pilot. Teledermatology contract has now been extended until the end of this year with the current provider, and the reason we extended the current provider is because we didn't want to put any new provider in and have new process in place at a time when the providers in primary care just need to carry on as business as usual, not have to worry about another provider and how long that would take. It also would have led to an interruption for maybe 3 months if a new provider came in and we had to mobilise. And new equipment's been trialled within the hospital to try and speed up referral and diagnostic capacity. The fifth bit to talk about is the screening and recovery, and really brilliant to say that we've had Public Health England gave additional funding to the Trust for a mobile unit for the breast screening to be able to bring down that backlog of appointments that have not taken place because of the pause during the COVID period. And it runs now in the evening and on Saturdays and Sundays, so doing extra hours and increasing that access. But more importantly, the hospital is targeting by the behavioural insights approach those people people who don't usually come forward. And we're seeing a really good impact on that. So we're having less people not turning up for appointments. And as Nick mentioned before, we're really pleased to say that we've got Community Diagnostic Centre opening in the middle of Glassworks, and we received £2.3 million to be able to open that Glassworks. Sorry. Thank you for my tea. That Glassworks Community Diagnostic Centre, and where it's in the middle of the shopping centre, it's going to have a feel and a decor that is not medical. It's going to feel like that you come for screening diagnostics just as what you do as business usual. Same way as if you went to the cinema, you think, I'll just pop in and have my screening. And it's all about making sure that people have better access, easier access, because the Glassworks is in a place where people would go usually, but more importantly, it's got great parking, great transport links, and we're trying to make it accessible. So we are moving the screening services, breast screens, into that Glassworks. But that will free up space then at the hospital main location to be able to put more appointments on for other diagnostic tests. So we're really wonderful. We think that's fantastic. I hope the governing body agrees that that is an amazing piece of work. We are nationally, everybody is very pleased about that we've gone through a shopping centre and done it this way because we are innovative, and that's how they want the community diagnostic centres to deliver. And more importantly, we've got one additional breast screening unit out of this CDC funding, so we'll now have 2 breast screening units where we've only got 1. We're talking to people at the moment to ask them how they want it to look, and more importantly, how do we make it accessible and it does meet their need, and we're in engagement around that. And there's the CCG is part of a group with the hospital and an engagement quality group where we are making sure that we're using the quality impact assessment and the feedback we've had through engagement with patients to make sure this centre does feel and meets the needs of the patients of Barnsley. Finally, on another good note, Barnsley is going to be part of the lung health check scheme, which starts in autumn, hopefully in Barnsley. And what that does, it provides a low CT scan to people at risk of lung cancer. So that's people 55 to 70 who have smoked or are smoking now. And it provides a CT unit that is mobile, that goes not to medical places but to shopping centre, work and men's club. And then people who are at risk are called forward to come and get screened. It will probably start in the Durn area first, giving health checks, these lung health checks, because that's our area of highest lung cancer and highest risk. And this is a programme that is for 3 years. So anybody who's worried thinking, oh, it's going to the Durn, is it going to go to our area, or when will it come to us? It will come over the next 3 years for the whole of Barnsley. But we want to do it based on health inequalities and what's the greatest benefit where we go first. So to summarise, I think that we would like to say, Dr. Kadash and I, that we hope that this assurance report gives you the assurance that the Barnsley Cancer Steering Group has got a robust assurance in place for the programme deliverables, but also for the delivery of the long-term plan and for the Cancer Alliance priorities that we all agree as an ICS. We've got mitigating actions in place and very clear, robust improvement action plans that for assurance that are monitored on a regular basis. And we continue to encourage people to come forward who have not come forward to address any referral changes. And finally, just wanted to say to reassure the governing body that there has been no disruption at the hospital for cancer referrals and cancer services over the last 6 months or during this pandemic, and the hospital continue to prioritise and assure the CCG that cancer referrals are prioritised above everything else, and that would be the last area that they would not prioritise. But as I said, that is occurring at the moment. There is no expectation that that position will change, i.e. that the Trust will not prioritise cancer. So I ask if people will accept it.
Sorry?
So I ask if they'll accept the assurance report, and is there any questions?
Thank you for that. Very detailed and comprehensive. But I wonder if the governing body might have some questions there. Certainly there are some things that popped into my mind while I was reading that report. I don't know how much time we'll have to discuss them all, but there are a few issues. So first of all, Chris Millington.
Well, as a non-clinician, as a lay member, certainly the good news for Barnsley is this community hub, assessment hub, brand spanking new in a brand spanking location in Barnsley, as Siobhan has said, right on the doorstep of the bus station, the taxi ranks, the railway station. I personally am really revved up about this, and I know maybe the clinicians will say yes, but I think this is a fantastic opportunity to deliver on care closer to home, breaking down the barriers, delivering seamless care. Revved up about it, really pleased.
Good. Any other thoughts or reflections? Okay, so if there aren't, just very quickly, Siobhan, on page 160, you talk about CCG breast screening. And what we see there is that our CCG is well below the UK average. So you then give a distribution of its variation across practices. And I think what we said before, practice areas, breast screening is not a function of the practices, so it's of little value. We need to have that based on localities, and then we need a pragmatic approach to increasing and improving breast screening rates in the localities where it's down. So with that in mind, I just wonder if the mobile breast screening unit could be deployed in those localities where the breast screening rates are down, because one of the things is people accessing the hospital. So I think we need to bear that in mind. I think, and actually I'd task you and Hussein to come back with some sort of plan around that. It may be we can't do that, but we can devise a plan to look at which localities have the lowest breast screening rates and increase those, because we're significantly below the UK average. Second thing is referral to treatment, care navigators and quality of life. I think that's really good and really wise, holistic approach, but what it won't do is improve their prognostic outcome from cancer if they're waiting in that 62 days. So I think there has to be another action in there about what improves and how the prioritisation takes place to improve their prognostic outcomes, not just the quality of life. Because there is something in cancer about, yeah, obviously holistically approaching that, but people need to get their treatment early. That's the key message. So although it's an additional and welcome service, there is something about getting those people treated quickly. And the third thing that made me just think a little bit is lung health checks. Great, they're coming to the Dearn, but we're doing 4,079 health checks and finding only 7 early cancers. Now that doesn't seem to fit with the high incidence of cancer that we have in the Dearn. So I just wonder if there's something there around these lung health checks that can make them more effective or more wide scale, and where the yield could be higher than 7 out of 4,000 health checks. It seems for those 7 people it's great, but it seems a lot of effort. And are we missing other people? Should we be doing more differently? So those are the things that I picked out of that report. And not today, but I think at some, perhaps at the next meeting you could bring something back. What I would say is that I think we do feel generally assured with the work that's happening and the great potential of the diagnostic hub, which hopefully people will be more inclined to turn up to appointments if they happen to be in town or near the glassworks anyway. So once again, are there any other thoughts from the governing body members, or shall we? Okay, so thank you, Siobhan. Express our thanks to Hussein, and we'll move on to item 14, mental health update.
Thank you.
Thank you. Thanks, Siobhan. Is Patrick here?
Patrick is not here at the moment. Do you know something I don't, Jamie?
Yeah, is poorly. Not sure whether Patrick may have COVID, but not feeling well under it. So I'm going to try and take governing body through and highlight the key points, Chair, if that's okay.
Yeah, and I think that this one and the maternity update, they're quite well articulated in the paper, so I think you could stick to the main points and assume that the papers have been read. Thanks, Jamie. Thanks for stepping in.
Thank you. So I will absolutely do that and assume that everybody's had the opportunity to read. From a mental health perspective then, I think the key points are all age mental health strategy. So governing body members will be aware we've been working on that out currently for public consultation, an expectation that the final draft will go to the Health and Wellbeing Board on the 3rd of February. So that strategy has been developed by the partnership. Once that is signed off, there will be strategy delivery plans for each of the work stream, and we'll be able to share them at future meetings. Other key areas, specialist perinatal mental health service is covered. That is expanding as per national recommendations, so no issues there. The IAP service is highlighted still not achieving the access target. There's information there around the number of patients. So the end of November, I know that's a bit dated, but 951 patients short of the target. Not necessarily capacity for them first appointments, and the service are trying to use a number of ways to promote IAP services and encourage referrals through, including the self-referrals. We're getting support across the ICS on this in terms of sharing best practice and looking wider than South Yorkshire to look at what others have done, and that's in recognition that across South Yorkshire other areas are also struggling to achieve that target. All of the other IAP targets are currently being achieved, and we're seeing good progress in terms of people moving to recovery or people making reliable improvement. Still got some challenges which governing body members are aware of in terms of CBT pathways and second weights, which is why when we worked through the mental health investments at the previous meetings, that's one of the areas that we agreed to put some further investment for. So that's been taken forward. There continues to be a focus nationally, but an impact in Barnsley on eating disorders, high levels of referrals into children and young people's services, and the issue then being a lack of tier 4 beds across the country. So work is still progressing to develop the local all-age eating disorder pathway, and there's work with the mental health sort of collaborative around eating disorders to try to resolve the bed issue, but it remains as it was at the moment. Crisis care, again, service pressures, particularly impacted by staff absences. We're due to undergo the procurement for safe space crisis alternatives. So again, one of the areas from the mental health investment, the service spec is drafted and the tender documentation is being developed for that. And then the one other thing, I guess, or two other things to flag. So one is around our sort of intentions around the development of a single point of contact for CAMS services and children's mental health and wellbeing services. So that's included in our spec. The intention was to go live with that from the 4th of January because of the pressures in the system, staff absences, reprioritisation of mental health staff to make sure they could support people on their wards and other places. That has had to be pushed back and is now expected to be in February. So worth noting that. And then final point on mental health is just to share with governing body members the schemes that were put in place to support discharge and seasonal pressures. So this were some funding with specific for the specific purpose of supporting provider resilience from NHS England. So Patrick, working with all of our providers, including the independent sector providers and the partners on the mental health partnership, worked through and agreed those. So they're there for you to note. And that money is supporting us through winter. And they're the key points, I think. So I'll stop there. And if there are any questions, I might be able to answer, or otherwise I'll take back and bring answers.
Yeah, I think that will be good. I think first of all, we all hope that Patrick gets well soon from the governing body. And the second thing is, if there are any questions, Jamie can pass them on to Patrick when he's feeling better, I think. So do governing body have any questions about this mental health update? No, none at the moment. Okay, that's good. So thank you. Can we then move on to you taking this for us as well, Jamie?
Maternity?
Yes, please.
I am, and Viv Williams is observing the meeting today, but has been working with Patrick on some of the work around maternity. So if there are any questions between us, we may be able to answer. But again, if not, we can take them back. So the key areas, again, I'll take the paper as read. Key areas here: successful positive thing. So Barnsley are successfully achieving the continuity of carers target. So that were one of the things that were included in the long-term plan and in the requirements for maternity services. So that's good, and we're achieving the target for March 22 already. We've received positive feedback following Barnsley's submission of evidence in the response to Ockenden. So the second phase of the report is due to be published in March 2022. So positive. We continue to expand the specialist perinatal mental health services in line with national recommendations. So again, a strong area for Barnsley. Continue to deliver significant work to reduce the smoking rate of mothers and pregnant ladies. We've received some funding from NHS England for year 3 of that programme. So that's been taken forward. Work is also being progressed to develop a maternity partnership, which is a sort of engagement forum, which will allow sort of pregnant women and other stakeholders to be more involved in and influential in the design of services. And work's also progressing to have BAME mums involved in service design to ensure that services are meeting their needs and taking account of issues that they may face. So they're the key areas in there. We've not got anything otherwise to raise. So that's hopefully gives governing body some assurance around maternity. But as we said, any questions, I'll take them.
Okay, Chris.
Yeah, thanks, James. I think you probably undersold it there, actually. So on continuity of care is where a mother receives the same midwifery team both pre and post birth, and as a named midwife. So Barnsley's the highest performing area in South Yorkshire by some considerable way. So I think in terms of the standards and the quality of service that Barnsley Hospital's currently delivering is absolutely exceptional, and it's compares very, very favourably to other hospitals in our area.
Yeah, thanks, Chris.
Good. Thanks, Chris. Are there any other points anybody wishes to bring up? No? Okay. Thanks, Jamie.
Thank you.
Can we then move on to item 16, assurance report, continuing healthcare, our quarterly report on lit and complex cases. Jane, has Jo joined us?
She is, Chair. Jo's joined the call to take us through the main points of the paper.
I am. Good morning, Chair and members. I'll take the paper as read. Just wanted to draw your attention to a few key points. First of all, on the CHC part of the paper, the staffing situation. 2 nurses due to go on maternity leave fairly imminently in February. 1 nurse due to return. She's an acting team leader at the moment. She's a full-time member of staff, but it is anticipated that she may request to come back full-time, so that will present a bit of a challenge there. But looking at agency cover, it's not ideal. So really that's a situation that they're finding increasingly and ongoingly challenging. So just wanted to draw your attention to that one. That said, outstanding reviews are in a good position. They're at 8%, which is favourable with our partners locally and quite regionally as well. They're meeting the KPIs apart from, I think it was November 28-day standard, which was, there was some issues around social workers engaging with the DST process, and that's been addressed by conversations directly and also at the interface meetings that we have with Barnsley Council. But again, they've got their own staffing pressures and workload, so we're trying to work, very collaboratively with them and sensitively on that one as well. The extension of the COVID 4-week monies, which is easing financial pressure in terms of discharge to assess for a little while longer. Those were the highlights on CHC Are there any questions about the CHC part before I move on? No. Okay, complex cases. Again, one of our main points is staffing. We lost our CHC nurse assessor and case manager in November. We presented an opportunity, though, to do something a little different, and we put a business case in to change the Band 7 post that he occupied to take on the Transforming Care cohort, which currently the complex case manager for adults has took on board when she started post over 2 years ago. And it's really stretching. So we felt that we needed to bring that into one area and have some focus on that, because there's some issues to work on around the risk registers and the way that we manage the CETRs for children there. That post out to advert, the closing date's end of the week. We had it out on a South Yorkshire wide. It's gone national now because we got nothing from South Yorkshire adverts. So we're hoping that there's something. I think there's a couple of applications, so I'm going to look at those after the weekend when the closing date's gone. We've also we submitted a business case successfully for a 0.6 CHC nurse assessor case manager, because we felt that we've only got 14 cases now. There are a couple of referrals in that we're screening, but we don't anticipate a huge rise in cases, and we feel at the moment a 0.6 whole-time equivalent will manage that. Again, a couple of applications on the national advert, so we'll have a look at those, but we may need to go back out to advert if there's nobody appointable at this point. But in the interim, we have an agency nurse started on Tuesday, and she's here till the end of March for now. So we may need to request to extend that person, but she's got a lot of experience, and she's also worked in Barnsley at Greenacre School, so she's quite an asset for us for the moment, and she's getting on with the outstanding reviews. The audit revisit is almost complete. Testing is just at the final stages, so we're hoping to have some answers about that and about whether we measure up to the changes that we've put in place in the team. So that will be interesting to see, and we'll obviously be feeding back at our next update to governing body about that. The next thing is an innovation. We're changing our database and putting everybody on our Section 117 cohort onto System 1, which helps with continuity of record keeping and the quality of record keeping. And also it helps us align things better to what's happening on Broadcare. And we're doing some work on Broadcare as well to try and align the financial stuff. And our BST has just got some more functionality. She's just had some training and functionality, so she's able to do more recording. So she's understanding Broadcare and learning it a lot more. So hopefully we'll be able to get that tie-in that we need with finances records there. So we're still working actively on that. And I think that's it really. Apart from neuro, we are still working with the neuro pathway review, just finalising a standard operating process to put in place for the IFR funding for 2 points of entry. So that's a piece of work that will have completed soon, and hopefully that bit of the pathway will be a lot smoother. And I think that's it, Chair and members. Are there any questions?
Not a question, just a comment, Joe. So you've got some challenges, which are, some are operational, some are almost operational strategic, and the others are recruitment and retention and capacity. But overall, the story seems to be improving quite a bit. I don't know if that's safe to say, but it feels that we've got a better handle over the past 6 months, and the reports from incoming to governing body, that we're better informed. We've had a deep dive. We know where the issues are, and we've taken some steps to do what's within our gift to do. Is that?
I think that's a fair assessment, Chair. Yes, I think we are. We've still got work to do, and but we know what we need to do now, which is a much different place to be in.
So do we feel as assured? Does the rest of the governing body feel as assured as I am? Yeah. So good work, carry on. Thank you, Joe, thank you, Jane, and we'll probably see you in a quarter or so, won't we?
I think March is my next date to report back.
Right, okay, we'll see about that. Good, so I think it does feel better, and it feels if you and Jane and the team are more on top of things, and you're less likely to find now, I think, any surprises. You know where the challenges are and you know what you've got to do. So that's really good. Well done. Thank you.
So thank you.
Okay.
Good morning. Bye.
Thanks, Joe. Thanks, Jane. Can we then move on to item 17, Jamie? Outcomes of the SEND inspection, please.
Yep. So, thank you. So yeah, this paper is intended to present the letter that we received following the SEND inspection, which took place at the back end of September this year. The purpose of the inspection was to review how well the local area meets its responsibility for children and young people, so those aged 0 to 25 who have special educational needs and disabilities. The inspection team looked at evidence for how well children and young people with SEND are supported through 3 key areas. 1, how well we identify the needs of this group of children and young people. 2, how well we assess and meet the needs of such children and young people. And then 3rd, how successful we are at getting the best outcomes for those children and young people. During the week or 2 preceding the inspection, we provided lots of information across all of the health services that are supporting, and also education services, to make sure that the inspectors have got a good understanding of Barnsley. During the week or few days that they were on site, there were over 30 focus groups took place, meetings with a wide range of stakeholders across education, health, children's services. They also met with people from the Barnsley SEND Youth Forum. They met children and young people in local schools or settings, and they also engaged with parents and carers, and they did a survey to which they received 600 parents and carers responses to that online survey, which were exceptional in terms of the response rate. The letter's attached that sets out all of the details that were published on the 19th of November. I think the letter notes the progress that has been made over the last few years. It also highlights that since the framework and legislation came in, that in Barnsley we were probably a little bit slow in commencing that work. So there are still some areas where further is required. Where the inspection identifies any areas of significant concern, they highlight this and require a written statement of action. And in Barnsley, there were 2 areas flagged, which are at the bottom of that second page. So the first was around engagement of and communication with parents and carers. So local statutory partners need to ensure that the lived experience of families is influencing their strategic plans for service and provision. So lots of good in the inspection report around engagement of children and young people, but more needed with parents and carers. And then the second point was around improving the identification of and provision for children and young people with SEND, but without an education, health and care plan. So those people identified with potentially lower levels of need who can be supported in schools. So more work there with the academies. From an health perspective, there's lots of good points drawn out in the report. So they make reference to, this is quite apt given the paper that we've just talked about. Midwifery service, really positive reflection in terms of how that service works to identify needs early, shares the information promptly with other services. Health visitors, again, positive around additional CAMS offer, specifically aimed at this cohort. And also our therapy services. So some strengths in there. I think from an health perspective, there are a couple of points that we will recognise and will work on in the improvement plan. So one is that too many children and young people continue to wait too long for support for their social, emotional and mental health needs. It does note that leaders have recognised this and we've got plans in place, but obviously there's work to do. And the second, which I think is an important one to note, is around transition to adulthood is underdeveloped in some health services. So for some young people, there's no equivalent adult health service, and the impact of that is that it can cause anxiety and stress for the young people and their families in terms of how they'll be supported to manage and access services in future. So again, they recognise that we are aware of this and that there's ongoing work, but more to do. In terms of the two formal written statements, where this sort of occurs, we are required to do a response to Ofsted and DFE. We've got to do that by no later than Monday, the 28th of February, and then that will set out our plan for improving those two areas. The work that we're doing with our partners in the local authority and providers is actually looking at all of the areas that are identified as areas requiring further development or weaknesses, and bringing them forward to refresh our SEND improvement plan. But we will submit the written statement of action by that date. Ofsted and CQC then have 10 days where they will review the fitness and purpose of those written statements and plans. When that is deemed fit for purpose, the DFE, working with NHS England, will then provide support and challenge to the local area, and they continue to work with us over an 18-month period and come in four times during that to see where we're at. There's usually then a re-inspection, but there's a change to the inspection framework coming. So any area that were inspected after June 21 will not be revisited under the current framework, but any subsequent visit or inspection will obviously look at the areas that have been identified to see if there's progress being made. So I think that's the report. It's there for governing body members to note. I think it does show some positives in there, but it also shows that there are some areas where we still need to develop, still need to do more in partnership together with our local authority. So I'll leave it there, but I can take any questions on that one.
Okay, do we have any questions or? No. So I've got one, Jamie. I think you're right, there are lots of positive areas here, and I think one of the ones for me that makes me optimistic about improving those areas that need a little bit of improvement is the fantastic engagement that this got. Because you said they got 600 responses to an online survey, but they also interviewed, it says, over 200 people.
Yeah.
So that's massive engagement, isn't it? So in terms of being marked a little bit low on some of the influence of the public and carers and patients on design, they've got grounds for optimism there, because people are quite clearly willing to share their thoughts with them. I mean, 200 interviews is it's extensive, isn't it?
Yeah. So parents, carers, children, young people, and but also all of the services who provide support also were able to participate and share their view, and are all really positive around how we can take this forward and the direction. So I think there's definitely something to build on there. And one of the things that I'm working on with Mel John Ross, the Exec Director of Children's Services at the Council, partially in response to that first statement, is establishing a parent-carer forum, or actually, so that's probably the wrong word, because the parents and carers have come forward and are establishing a parent and carer forum. They receive DFE funding to support that, but we're working with them, engaging and looking at how they become part of the system to inform our plans. But that's a real positive move if we can bring that on.
Yeah, and I think in terms of supporting that, quite often you find that these forums are set up by some very enthusiastic individuals, and the trick always is to keep them going, support them, get new people through as their children grow up, yes, so that you can maintain that level of influence and that ownership in shaping the service. So those are all grounds for future optimism. So if there's nothing else from governing body, thanks again, Jamie, and can we move on to Jane, item 18, quality highlights report, please.
Thanks, Chair. So the Quality and Patient Safety Committee met on the 16th of December and wanted to highlight 6 quality issues to the governing body. So the first one is with regards to the Medway presentation that the committee received, and the committee were reassured that BH&FT were progressing the digital capabilities and that these will generate quality improvements. The second is an update on Barnsley Hospice CQC. So the committee was again briefed on the improvements made at Barnsley Hospital in connection to their unannounced CQC visit back in the summer 2021. I do have an update for governing body. Obviously things have moved on considerably since this. So the CQC made an unannounced visit last week, which they can as part of the process. And last week they reviewed the treatment of disease, disorder or injury domain. They have written to the hospice, and the hospice are now obviously putting in a response to that. The CQC have been again this week to review the areas of the well-led domain, and the hospice are waiting for that written letter with regards to that. So I continue to meet with the Chief Executive, Chief Nurse of the hospice, and so obviously does the CQC. So the committee noted the ongoing work and agreed that the committee would continue to monitor the progress. So obviously any feedback, any information we receive will go back to the Quality and Patient Safety Committee. The third is oncology provision. So Siobhan touched on this in her paper earlier. So the committee received an update on oncology provision for Barnsley patients following the temporary decision by Western Park to cease providing face-to-face appointments at the hospital for colorectal and breast oncology patients. So the committee received details of a range of actions which will take to mitigate the potential risks. So the committee noted the latest position and again will continue to monitor the impact of the current arrangements. So Siobhan does attend the Quality and Patient Safety Committee every time to update on progress and works with the committee to understand that. So the fourth is the lymphedema service update. As the governing body knows, the hospice gave notice to the CCG, and there was a gap between the hospice handing in the notice and SWIFT being able to take up the service. So the CCG took the lymphedema service in-house, so set up processes and standard operating procedures and clinics and brought it in-house. So I do have an update on this. So the service will move now to SWIFT on the 17th of February. So really good news. Elizabeth Locke, the CCG, one of the CCG nurses, has really worked hard and carried the service from a clinical perspective whilst it's been in-house. So my thanks to Liz for doing that. So good news, we'll be moving to SWIFT, and Liz will work with SWIFT with regards to the clinical handover. The fifth is urology. So the committee received the results of a thematic review of urology incidents which have been reported to the CCG. We'd had a number of STICE reportable SIs that we've received over a couple of years, but certainly an increase over the past 12 months. So I asked for a thematic review to be carried out. The committee was informed about the actions being undertaken by BH&FT. but the update to the committee also highlighted wider concerns to the CCG about the hospital systems and processes for tracking patients that require follow-up and surveillance. The highlight report here says that the action plan has not yet been received. We have now received the action plan, and I've requested some further information from the hospital with regards to complaints that they've received about the service and so on. So widening the net really with regards to this service. We've pulled together an extraordinary meeting with the Trust, which will be next Thursday, the 27th of January, to seek further assurances about the measures that they're taking in relation to the urology incidents and the wider issues about patient follow-up and surveillance. So the committee noted the update, agreed it was not sufficiently assured regarding the actions being undertaken around the risks about patient follow-up and urology, and it was agreed that the outcome of the extraordinary meeting will be fed back to the next QPSC in March. The last one to highlight to the governing body is the staff changes to the CCG's core quality team. So as Joe informed earlier, we've got gaps and staffing challenges across the complex case portfolio and continuing healthcare, but we've also got challenges now within the core quality team that supports the serious incidents, complaints, and so on. So the committee was informed that the CCG's quality manager is due to leave the CCG on the 18th of February. This is a significant risk to the CCG to maintain the complaints and quality monitoring functions. There will be, and this highlight report says, if there is a staffing gap, there will be a staffing gap between the quality manager leaving and the start of their replacement. We went out to internal advert across SYB and we didn't get any applicants. We've been out nationally. The closing date was yesterday, and thankfully we've had 11 applications for that post. So positive, but we will obviously have a gap because the time's obviously quite short, and any potential candidate will need to give, you know, three months notice, and then we've got checks and so on. I did outline to the Quality and Patient Safety Committee the actions that we're taking to obtain interim support, and that included, you know, going out to our providers to see whether they can provide anybody on a secondment opportunity. Unfortunately, they couldn't, and I've also been across and asked for support from the South Yorkshire and Bassetlaw CCGs and the chief nurses there. We've in discussions with Rotherham and Sheffield to see what support they can give, because they think they might be able to provide something, but obviously not all of the portfolio. And we're also working with agencies to see if we can get somebody in the interim. So the committee noted the risk to the quality function and the arrangements that we're trying to do to mitigate the risk. So with regards to my portfolio, you know, we've got a number of staffing challenges across the whole of the quality team. So that's it, Chair. Thank you, governing body.
Thank you. Do we have any questions for Jane? Nigel.
Yeah, it's more of a process than the actual report. Where we've got red risks appearing on those, do they appear on our risk register? Because reading the risk register report that comes next, they weren't referenced, and I wasn't sure what the process was, to be fair. So.
Yes, they are, Nigel. I don't know if Richard wants to come in, but they certainly are. They are raised and on the risk register. Yeah.
Okay, thanks. So
they'll either be on now or will
be.
Go on if at the next meeting of the QPSC, for example, the assurance that they've asked for doesn't materialise or doesn't appear to have mitigated the issue, then the committee might decide to put it on.
Okay.
Mike?
It's about the quality manager. I mean, by the time you've advertised, interviewed, and they've given 3 months' notice, will the CCG still exist then? And I mean, how do they then legally tie into the whole process?
It's my understanding, Mike, that there will still be a requirement for this post at place to carry on these functions. I don't know, Chris Edwards, if you wanted to come in there too, guys.
So what we're trying to do, Mike, is keep, obviously, the CCG, we're trying to ensure smooth transition into the South Yorkshire Integrated Care Board. So as a management team, when we assess vacancies, we consider whether the requirement for the function will be required in the future. And when we've assessed this quality approach, we've assessed that they will be required in the future. So we'll recruit on that basis. And the intention would be that the member of staff would TUPE across from the CCG to the ICB on the 1st of July is the current working assumption.
Right, thank you. Thank you. I've got a couple of points, Jane, from other conversations in different parts of the system. The first one is oncology provision, and a concern that this was originally lower GI and has now moved to include breast, probably without much consultation with the Commissioner. There is a Western Park sort of initiative. The fear then is which cancer group will come next. Also, when Western Park made these arrangements, the explanation is a shortage of trained specialists, and I think that's, you know, very understandable. But on the back of that, they said they were temporary arrangements, and I think we need to understand what temporary means, because these things have a habit of becoming permanent. So I don't know in which forum, whether it's with the Cancer Alliance or where it is that this is taken up. I think others will be taking up this as well, because I think it's not a dissimilar situation in Rotherham, but it does. So, for example, one of the things is they said they would put on public transport for people, and you know, that could be of a variable standard and variably tolerable. So there are some issues around this being nipped as far as possible in the bud, so we don't widen health inequalities. That's the oncology provision, and certainly there are other specialities don't fall into that. The big one for us would of course be if lung fell into that, because that's, I think, one of our more prevalent cancers. So that was oncology. The second one was about urology incidents, and one of the big things that we have on a daily basis, just to feed back as a GP in practice, is urology queries and appointments, because patients just don't know, just haven't been contacted, they haven't had a letter, they don't know what their follow-up is, where they're supposed to have the next blood test, the next injection if they need them, and we're spending a lot of time trying to unravel that and sort that out. And so I think, I mean, obviously it's red and you understand that, but it is having an impact on primary care, because patients find us sometimes easier to get through than the hospital, and we can't say phone the hospital again because they can't get through. So we're trying to unravel some of this. I understand the difficulties the hospital are having with urology provision, but it is impacting significantly on patients. But I think you've identified that. Thank you. Chris.
Chair, I share you and agree with your comments in relation to the word temporary. This situation is very close to my heart at the moment, and there doesn't seem to be anybody who's prepared to give us a timeline on it. So it is a major concern for the people of Barnsley. Just to confirm, there is in fact a minibus service in place now, which Western Park have put into action, which at the moment starts from the football ground, but we're looking at a second pickup point, maybe at the hospital also. But yeah, temporary is not good in my world.
Okay, so I think all those points have been taken forward, and I think Richard has also articulated how they get onto the governing body's register if they're escalated. Okay, so if there are no further comments, we'll say thank you, Jane, thanks for that.
Thank you.
And can we move on to the next item, which is 19, Risk and Governance Exception Report. Richard, please.
Yeah, thank you, Nick. So possibly a fairly brief report from me today. It's predominantly just the usual update for governing bodies. So you've got the governing body assurance framework and also an extract of the red risks from the corporate risk register, and they are there for governing body to review and to be assured that those risks are being monitored and are appropriately articulated and scored in the risk register. So I won't say any more specifically about those things. The one thing I was just going to pick up on is, and it's picked up in the covering paper, is we have a risks. It's the reference 1313 in the risk register, which is to do with Yorkshire Ambulance Service and the potential risk to Barnsley patients if that service isn't able to achieve and sustain good performance, for example, in its response times. And as the report says, under the intense pressure that there's been in the system over the last few weeks and months, there's been some issues with that service. For example, it was communicated that the service intended to suspend routine patient transport journeys from the 12th of January, and there has also been evidence of a reduction in performance against response time targets and an increase in the number of incidents in relation to the ambulance service. And on the back of that, Jane, the chief nurse, is recommending that we increase the risk score allocated to that risk from a 3/5 of 15, which is what it is now, to a 4/5, which is 20. So it would remain it is already a red risk. It would remain a red risk, but in a sense, it's just a signal that we are recognising that increase in the likelihood that our population will potentially experience issues as a result of that pressure that the service is under. So I don't know if Jane or Jamie wanted to add anything to what I've just said there.
Jamie?
Just by way of update, and I don't think it changes the position because ambulance services continue to be extremely stretched, but we've seen something this morning. So the decision, or yesterday, the decision to obviously step down some of the PTS services because of pressures with ambulance staff to prioritise urgent care, that will no longer be required from the 24th. So from next Monday, the ambulance service have confirmed that their operations will be back to normal, so they will be delivering PTS. But I don't think that changes the risk position. It's just an update on that position.
Thanks, Jamie. Jane?
Yes, thanks, Chair. I think just to say, the significant risk that we do have with Yorkshire Ambulance Service, and that's coming out with regards to complaints and serious incidents. For the previous 2 financial years, we didn't receive any SIs for Barnsley patients, and we've received since April a number of serious incidents related to treatment delays and other issues. So it is something that obviously is significantly more than obviously we have seen before.
Thanks, Jane. So obviously the suspension of routine stuff was to switch capacity and I would imagine concentrate on the more urgent requests. In primary care, we've had a couple of circulars asking not to request inappropriate ambulances, which I would hope we don't do. But there have been long waits, 6 hours and things like that, for patients to be picked up who, if they need to go to hospital in the first place, 6 hours is quite a big delay. So I would approve the increase in risk score, but I'm not sure what's in the gift of the CCG to mitigate that, other than to monitor the serious incidents and keep in close contact with the AS and to make sure the lead provider's informed as well. Okay. So do you want to just take us through the governing body ask then, Richard, if there are no other questions out the assurance framework or the risk register for
happy to do that. Thank you, Nick. So the ask is, as usual, on the GBAF, just to review it and to consider whether the governing body feels the risks are appropriately described and scored, and whether you've got sufficient assurance that that these priority areas are being effectively managed. And I I think I'll take it as that we are. The next ask is to identify if we have any other additional positive assurance to add on to the assurance framework. Well, I've not heard that we do today. The ask is to review the corporate risk register and confirm that all the risks that we've got on the extract are appropriately scored and described, and related to that, to approve the increase in score in relation to risk 1313, the Yorkshire Ambulance Service risk. So that would go from a 15 to a 20.
Jamie?
Yeah, thank you, Chair. Well, just to make a point to members of the governing body, we had a conversation at Finance and Performance Committee around a number of the risks that have been impacted, particularly performance type risks that have been impacted by COVID. So, for example, there's one around A&E, there's one around cancer. So we said that we would have a look at those risks, reflect the current level, but note in the commentary the fact that they are impacted by COVID, and therefore there may not be lots of actions that we can take to address them. It was just for members that are on that committee. I've picked that up. They may not be reflected in the version of this risk register just because of timing, but next time there will be an increase in risk ratings for, or a recommended risk around A&E and cancer, particularly given the ongoing challenges. So, thanks.
Okay, thank you. So I think the governing body's given you everything you want on the assurance framework and the risk register, Richard.
Yes, thank
and
you.
on that new risk. Thank you for that, Richard. Thanks, Jamie. Can we move on then to item 20, integrated performance report? Roxanna, do you want to do the financial part first, and then Jamie can do performance?
Yeah, thank you. So just to note, before we get into the contents of the paper presented here today, the governing body will receive a further update following a review of the expenditure analysis undertaken within the finance and contracting team in our meeting in private later today. This report sets out the position as at month 8. So we've just finished reporting month 9, so it is a month behind. But in this paper, the CCG is on track to achieve business rules and will continue to be on track to achieve business rules, with at least a break-even position being reported. We're still waiting a number of nationally held allocations to be released to the CCG in relation to the hospital discharge programme, which is supporting discharge of patients from the hospital into a community setting or home, and the additional roles reimbursement, which is linked to the recruitment of additional roles within primary care networks. CHC, so continuing healthcare and prescribing continue to kind of be the highest risk areas within the CCG, as it does within all CCGs. And clearly we do have some volatility around these areas, but we are working very closely with the teams involved to ensure we can provide a robust forecast position included within the financial position, and we feel that this position reported does probably reflect where we might end up towards the year end. We don't see much fluctuation from that position. Not covered within the report, but also worth noting for the governing body, is that Chris referenced earlier planning guidance. So financial planning has commenced for 22-23. We are working on the assumption at the moment, despite the transition to the ICB, that we will develop a 12-month financial plan, with 3 months of that being phased for the continued existence of the CCG, and then 9 months obviously for the transfer into the ICB. There are conversations ongoing about allocations, however, because all allocations have been received at a system level and will then be determined how they are then split down into each individual place, and supporting conversations as well with our trust colleagues around contract values, etc. So it's probably just worth noting that that work has commenced, and the governing body will receive a full update on the position of that in March.
There's nothing else to note in terms of the financial position. Everything looks, we've got a fairly clear position in terms of where we might think we will end up at the year end. NHS England have made it very clear that the position that we reported at month 9 is the position they would like us to stick to as best we possibly can. So we have ensured we've done a thorough review of the financial position, which the governing body will be presented with later today. And at that point, I'll pause for any questions.
Any questions? No? Okay. So if there's nothing else you wish to add, we'll invite Jamie to take us through performance. Thank you, Roxana.
Thank you. So hopefully people have had an opportunity to read and look at the dashboard. I think the performance report continues to show the adverse impact of COVID upon delivery of some of our key performance targets, constitutional standards, including urgent care, referral to treatment time and diagnostics. Some of that has been reflected in some of the papers that you've received today. So the cancer assurance report covered off some of the cancer performance, and the mental health report covered off the challenges, particularly in relation to IAPT. Just to note to the governing body, there's been a little bit of work done on the performance dashboard. There's a few metrics that have now been included that haven't been throughout COVID, and that were following a data quality and performance management review by internal audit. So they're now reflected. In terms of the key points, so urgent care, A&E, as up to the point that is reported, which is November, but followed through in December, continue to be below the national 95% target for people to be seen within 4 hours, which, whilst I think we recognise that that is extremely challenging and probably is changing at some point in the future, it is still a standard. So only 65% of people were seen within 4 hours in November, and that were a bit worse than it was in the previous month. That's as a result of a number of things, including infection prevention control, including the high number of attendances that have been coming through the trust and the front door, but has also been due to bed occupancy levels and the ability to move people out from ED into beds when needed. So that's impacted. Ambulance performance we've just touched on in the previous paper, but continues to be extremely challenging. We noted that some PTS services were stood down to facilitate the prioritisation of urgent, and that will return to normal from next Monday. I've also noted in there the point that you made, Nick, around response times and the fact that they have been increasing, and obviously that has a negative impact for patients, so that's reflected now in our risk register. Planned care, so we saw a slight improvement in November, more people being treated within 18 weeks, still not achieving the standard but getting closer at that point. There is likely to be an impact when we see December's figures and January's figures, because there has been a requirement at certain times to stand down some cancel elective operations for patients where they were non-cancer and non-critical. So that's happened. We still have a number of patients, Barnsley CCG patients, who have been waiting more than 104 weeks. There's a real push to drive that down. A number are at Leeds Teaching Hospital, but we've also got a number at Barnsley Hospital as well, and they're working to make sure that those patients are booked in as soon as possible, and we continue to work towards reducing that to 0 by the end of March. Diagnostic performance, so still not achieving, again, the standard, but a big swing in terms of performance. So in October, nearly 30% of people were waiting longer than 6 weeks. That's down below 20% in November. So a positive move. We've continued on that path. There may be a little bit of a blip given what's happened in December, given Omicron and other things, but hopefully we'll continue on that journey. And then mental health and cancer, you've got the information, and I won't go into more detail because we've had an update on those already. So that's all I wanted to share, but I'll take any questions.
Okay, so I can't see any hands coming up, so just to recap over the ask of the governing body, we're asked to note the contents of the report, including performance 21-22 to date, and the projected delivery of all financial duties predicated on the assumptions outlined and mitigating actions. So if we're in agreement that we've done that as a governing body, I can't see any hands or dissension, then we'll move on to the next part of the meeting, which is the series of committee reports and minutes, starting with the unadopted minutes of the audit committee on the 25th of November. Nigel, is there anything you wish to add to these or say?
Just, I guess just to point out that these are to look at the transformational document that we need to report on. It was March, but now it's June. And only other point I would make is that the meeting in January is now being deferred to March in the light of the rescheduling of our work. So that's all I had to say. Thank you.
Okay. So we'll then move on to minutes of finance and performance. 2 sets of minutes, both adopted. They're here for information. Happy to take any questions. 4th of November and the 2nd of December. Is there anything in there anybody wants to pick up? No. So we move on to the assurance report of the Primary Care Commissioning Committee of the 25th of November and the minutes of the public meeting of the 30th of September. Chris, is there anything you'd like to highlight there?
Nothing to highlight, Chair, that we haven't already covered, so just take any questions if anyone's got any.
I meant Chris Millington.
Sorry.
But either one, any port of a storm. Primary Care Commissioning Committee, sorry, it may have been me, Chris. Chris Millington.
Thank you. Thank you, Chair. Well, I'll take September as read. A lot of detail in there, but it's many months ago. I'll just touch on November, if I may.
Yes.
November was all about telephony, and the aim of this project really was to give additional benefits, reduce call costs, to replace the ISDN 30 connections, which really is old now, and is really coming to the end of its life, to improve the system support. It will allow additional calls to be made at busy times. You'll note that the current cost of the CCG of providing telephony within lift buildings, and we're talking about lift buildings here, is shown on the table within the paper, quite detailed. The current spend circa cost per handset is between £20 and £50 per handset. So moving to a cloud system, which is what we're going to do, it will reduce the cost to the locations in questions to around about £15 per core handset. It also pays for the provision of non-core handsets throughout the building, which will benefit everybody and giving people more flexibility. The new service will be provided by a local Barnsley company, and cost then will come down to circa £14.80. The reduced costs are a large recurrent cost saving to the CCG from about £7,000 a month to £2,700 a month. Equally important, the work with practices outside of this LIFT programme will start to be planned to ensure we can move all practices to more modern connections and be more resilient in relation to the systems going forward. You may in actual fact find that within your own homes, landlines will shortly disappear, as and when you ask for better and bigger service. And I at the moment now have no landline. I'm working on a digital system through a home hub. So that's all I wanted to cover on both of those assurance reports, Chair. Happy to take any questions.
Okay, no questions. So then we move on to, thank you, Chris, minutes of the Quality and Patient Safety Committee back in October. I think they've been largely picked up in the quality highlights report that we've seen today. Is there anything extra, Jane, that you need to bring our attention to?
No, Chair, I don't think so. I think there's probably just one that obviously we've had the patient story today with regards to stroke and the hyperacute stroke unit, and this is something that we discussed at this meeting in October, and we requested that a piece of work needed to be undertaken to ensure patients seeking help at the right time. So that obviously just shows, you know, obviously a request by the committee and a piece of work that's happened. So just to highlight that.
Yeah, that's important, Jane, because from memory, I understand that the Hazoo bit of it is working well, but that there is still an issue for us in Barnsley in terms of how long it takes patients to actually present to any service. And that's something that we're working on, and that film will help with. Okay, thank you for that. So if there are no questions for Jane, we'll move on to assurance reports of the Quality Engagement Committee of the 18th of November. Is there anything in that, Chris Millington, you wanted to?
No, nothing at all, Chair. They're here for assurance. The only comment I would make is since the Colin Brotherston from Barnet moved away out of the country, his position has now been taken by someone called Roya Purali, who works in conjunction with us and our local hospital. And it was my first meet with that individual at that particular meeting. Since then, I've had weekly updates with Roya, so that we both understand what we need to get out of our assurance reports in relation to this area of our business. And that's all I need to say, Chair.
Okay, thank you. So then we've got some reports that were circulated in advance. One thing I would just ask, management team decisions around expenditure, have there been none in the past 2 months? Can't see your paper.
They go through the Finance and Performance Committee, Nick, and then are picked up in the minutes of the Finance and Performance Committee. So we wouldn't usually get a paper on that to the governing body.
Right, okay, so it's just me. So that would come through Finance and Performance.
Yeah. And
it would be in the minutes.
Yeah.
Okay, that's why it's not here then.
Yeah.
Right. So all that remains is just to close the meeting. Really, I just want to also pass on some thanks to all governing body members, from the chair of our Integrated Care Board, Piers Butler. When I met with him, he asked me to express, and I said I would express thanks to the governing body for continuing to the 30th of June end date for CCGs and for that extra commitment and support. And I think at that point we seek permission from members to move to the private part of the committee, excluding the public. I'd like to thank the public of Barnsley for joining the meeting and viewing it, and also for governing body, and Kay for patiently putting up with us and minuting. So at that point we'll close the meeting, and if we can stop recording, please, Kirsty.